Hi, Dr. Matthew Weiner from Commerce, Michigan, here to talk today about vitamins after bariatric surgery. Most of you know I'm a bariatric surgeon, but I'm also deeply committed to good nutrition and good health in my patients lifelong. And today I'm going to talk about a very commonly misunderstood topic, which is vitamin supplementation and the importance or unimportance of it for different groups of patients. So we'll start with our official recommendations. Now, I'm an active member of the ASMBS, the American Society of Metabolic and Bariatric Surgery, and we have a position statement and some guidelines that most of us will follow. And it's essentially that we recommend that everyone get 200% of the recommended daily allowance of the essential vitamins and minerals. Most over-the-counter vitamins that we have out there, such as Centrum, contain around 100%, so that would mean that you'd have to take 2 of these vitamin tablets. We recommend, at least for the first year, that this be a chewable formulation. It should contain iron, and it should contain a special type of iron known as chelated, and we'll talk about that a little bit more in a few minutes. And finally, that it should contain vitamin D, and we recommend 1,000 to 3,000 units, which is much more than you'll find in most store-bought vitamins. Most of them will have anywhere around 200, 400, maybe 800 at the most, but it typically requires a little more than that. So these are our basic supplements, and this is a lifelong recommendation that we make, but I'm going to talk a little more in detail about how this should be interpreted by certain groups of patients and what some of the pitfalls are of over-supplementing or under-supplementing. The first thing to talk about is that the supplementation importance depends on the surgical procedure. So we really have a spectrum of invasiveness, and as we move from the gastric band to the biliopancreatic diversion, we really have a less invasive surgery, the gastric band, all the way up to the biliopancreatic diversion, which is an extremely invasive and life-changing operation. So with the gastric band, because we're not making any alteration to the intact anatomy, there's no rearrangement of your gut, we will recommend vitamin supplementation, but the importance of this has really never been demonstrated. And my response to band patients who ask me about vitamins is, why not? Because vitamins are really fairly well tolerated, and it probably won't hurt anything. In fact, it almost definitely won't hurt anything. But as far as me saying to a band patient, if you don't take your vitamin, you're going to run into trouble, I can't tell you that. I really just can't say that. And I think most of us state the importance of it for this group of patients. There really are fewer and fewer gastric bands being done in this country, so this is less and less of an issue. The next operation up the invasiveness spectrum is a sleeve gastrectomy. And although there is no rearrangement of the gut, there's no change in the absorption, we do see some vitamin abnormalities in these patients, and it is probably very important that they remain on lifelong supplementation. I'll talk a little bit about specifically what supplements are important to follow up on over the years. The gastric bypass, without question, we know it's important. However, what most people think of as the deficiencies, the B vitamin deficiencies, such as thiamine and niacin, we really don't see that often. Instead, we're seeing some other issues. And with the biliopancreatic diversion, it is without question a matter of life and death. Failing to supplement after a duodenal switch will absolutely 100% of the time result in illness. And although I don't do these procedures, I see some of these patients in my office, and it is absolutely critical that we remain hypervigilant over the years. Decades after the procedure, we still must be checking the lab values at least yearly, probably twice yearly, and the supplementation must persist. But before we go into taking your vitamins, and I want to really make a point that taking the vitamin pill is not the same as eating the vitamins. And although we know about, say, 20, 30, maybe even 40 of these essential vitamins and minerals that you can become deficient in, what we really understand about these is that there is a direct deficiency to disease linkage for these vitamins and minerals. Whereas if you don't have enough thiamine, you will develop a very specific disease related to thiamine deficiency. If you don't have enough iron, you'll develop anemia as a direct result of not having enough iron in your diet. But there are thousands, if not tens of thousands, of what I refer to as phytonutrients. These are compounds that exist in plants primarily. In fact, by the term phytonutrient, we're really specifically talking about the plant compounds that don't directly link to a disease. If you're deficient in one, you won't absolutely develop a disease. However, deficiencies in many of these compounds, which work together and help to promote health, will in the end lead to diseases such as diabetes, such as high blood pressure, and ultimately perhaps lead to weight gain as well. So just because you are taking a vitamin pill, in my mind, does not make you immune from malnutrition after these surgeries or immune from some of the problems that you can get from undernutrition. And without question, eating your vitamins, taking in large amounts of green leafy vegetables, the set point smoothies that we talk about, and other vegetables and fruits and nuts and beans which contain these essential phytonutrients is mission critical to your success after surgery and should not be ignored at all. So back to vitamin supplementation, I think it's important for us to understand that it does change over time. And again, I'm really not speaking about the biliopancreatic diversion or duodenal switch procedures where it is mission critical from day one to the day you die. This is really speaking more about sleeve gastrectomy and gastric bypass. But in year one, it's absolutely critical, particularly for the gastric bypass, because you're taking in so little food, particularly in the first 6 months, that if you don't have a significant store of some of these vitamins and minerals, you can develop deficiencies, even the B vitamin deficiencies, in this 6-month period. Again, by following our early postoperative eating and taking in some of these set point smoothies as soon as you can after surgery, and not necessarily following the protein first model that's so eagerly promoted, but instead the vegetable first model that we promote in our practice, you can eliminate or decrease your risk of developing some of them. But within that first year, particularly that first 6 months, it is critical that you take in enough that you take your vitamins on a daily basis. In year 2, it still remains important, but beyond year 3, it's very variable. A lot of patients have no issues whatsoever with vitamin deficiencies after year 3 and could probably do just fine without taking even a regular over-the-counter store-bought multivitamin, particularly those who are eating on the pound of cure eating style. But there are other groups of patients who it is absolutely still mission critical. And I've had patients admitted to the hospital for iron deficiency 4, 5, 6 years down the road. And so although it would be nice to be able to ignore this requirement after surgery, you don't know which group you're in. You have no idea whether you are someone who is going to be dependent on lifelong supplementation or not. Staying in touch with your bariatric surgeon and continuing in your yearly follow-up 5 years, 10 years down the road is critical to make sure that you don't fall into this group. So let's first talk about the sleeve gastrectomy, because each procedure has some slightly different nuances when it comes to vitamin supplementation. With the sleeve gastrectomy, one deficiency that we're concerned about is vitamin B12. And the reason for that is that the stomach makes a protein called intrinsic factor. And when you eat vitamin B12, it has to bind to this intrinsic factor before it can be absorbed. And when we resect 2/3 of the stomach like we do in the sleeve gastrectomy, we may have a deficiency of intrinsic factor and we may see some vitamin B12 deficiency. Now there's a whole cottage industry which promotes B12 injections and the intranasal B12 formulations and other ways that you can take B12 without just taking a pill. That probably is unnecessary. And in my patients, a simple B-complex vitamin, which almost always contains B12, or an isolated B12 supplement, which is always a very small pill, very well tolerated, will absolutely prevent this issue in, I would say, 99% of sleeve gastrectomy patients. So although it is an issue, it's a very easily treatable deficiency in the rare circumstances that it does develop, and does not require special injections or nasal sprays. There's a real myth out there about B12 injections, and I've heard many patients in my office say they have to go back and see their doctor for a B12 injection because they're just really running out of steam and have a lot of fatigue. There is not this direct relationship between fatigue and a B12 deficiency, and it's probably an unnecessary thing to have a B12 injection, especially for a vague symptom like fatigue, which could have 100 different causes. We also see in sleeve gastrectomy patients a higher rate of iron deficiency for reasons that aren't unclear, because we are not we are not rearranging the intestine with the sleeve gastrectomy. But what we're probably doing is that we're speeding the flow of food through the stomach and through the first portion of the intestine. And this, in fact, may have something to do with the weight loss effect of the sleeve. Beyond the removal of the stomach and the metabolic effect and the restriction that this causes, we're also seeing a more rapid transit of food through the intestine. And what we know is that iron is absorbed in the very first portion of the intestine. At least one form of iron, elemental iron, which is how we take in most of it in our diet, is absorbed in that first portion of the intestine. And by increasing the rate at which the stomach empties into the duodenum, that's that first portion of intestine, we may see some iron deficiency as a result of that. It's unclear, this hasn't been fully worked out, but if you're a sleeve gastrectomy patient out there, you should have your iron levels checked yearly. You will not have the same dependence on these special chelated formulations as the gastric bypass patients do, for reasons I'll explain in just a second. So with a gastric bypass patient, believe it or not, B vitamin deficiencies are very, very uncommon down the road, unless you're someone who is just not eating any fruits and vegetables. And what we find is that in patients who eat fruits and vegetables on a regular basis, this is really pretty much unheard of. But what we do see a lot of, when I say a lot, I mean about 5 to 10% of my patients, is severe iron deficiency. And here's the classic scenario of a gastric bypass patient who develops severe iron deficiency. Typically doing well, living their life 4, 5, 6 years out from their surgery. At this point, don't really think that much about their surgery. Often still very involved in their diet and in their weight maintenance, but don't really look at themselves as a post-op patient who requires special treatment and special monitoring. And they'll be moving through their life, doing very well, and then for whatever reason, they'll become completely fatigued. They'll show up to their primary care doctor and say, I'm having trouble walking up steps, I'm worried, did I have a heart attack, what's going on? And the primary care doctor will take their blood and then send them home. And then later that day or the next morning, they'll get a phone call from their primary care doctor saying, your hemoglobin level is 4. A normal would be somewhere between 12 and 15. So your hemoglobin level, your iron, which is a measure of the amount of blood you have, the amount of red blood cells you have, is 1/3 of what it should be. I want you to go to the emergency room immediately. You've got to be bleeding. And so the patient will get very nervous and scared, go to the emergency room, be seen in the emergency room, be admitted. Well, they'll end up undergoing upper and lower endoscopy, so you're going to get a colonoscopy out of this whole episode. They'll get a hematology consult. They'll get an iron infusion and several units of blood transfused. And then finally, it'll be determined that they are just profoundly iron deficient from years of not following up and checking this. What we often find, too, is that these patients are put on a regular iron supplement. Ferrous sulfate is the typical supplement, and there's oftentimes some enteric coating of the pills that they give to make it gentle or slow, and there's a number of different drugstore variations. Because the elemental iron, which ferrous sulfate would be considered, is absorbed in the first portion of the intestine here, and the food that you eat is going to bypass that first portion of the intestine. There's a decreased ability for your body to absorb iron. And instead of ferrous sulfate, we recommend a chelated iron formulation, which means it's bound to a salt or a protein. And in this form, it can be absorbed at any point in the intestine. And it's critical that you consult with your bariatric surgeon and make sure that the iron formulation you select is available. These are rarely sold at drugstores, occasionally sold at some of these vitamin shops or GNC nutrition centers. In my practice, we offer them for sale to my patients so that there's no confusion. But one of these formulations is absolutely critical for supplementation. And if you stay and have your blood checked yearly and take the appropriate supplementation, 99% of patients can prevent any severe iron deficiency, any need for iron transfusions or admission to the hospital or any of this scare that I've seen patients subject to a number of times. And it's the nice thing about these chelated iron formulations is that they don't cause constipation. They're very well tolerated. That's one of the biggest issues with iron supplementation, is that patients will go on the ferrous sulfate and will have severe constipation and will end up becoming non-compliant, rightfully so, with their iron therapy. With the chelated formulations, we get a lot better compliance. Patients tolerate these just well. I've almost never had any issues with the chelated iron formulations, and patients tolerate them quite well. So again, if you're a Roux-en-Y patient, you take one thing out of this discussion, it's that you should have your iron level checked yearly. And if you do require supplementation, if there's signs of anemia or low iron levels, that you talk to your primary care doctor, you talk to your bariatric surgeon about finding a chelated iron formulation. With a biliopancreatic diversion, and this is critical for anybody who's had this procedure and is struggling with their health. Oftentimes it's these enigmatic, unknown health concerns. My kidneys are failing. Nobody can figure out why. My heart function is not what it used to be, and nobody can figure out what's going on. Oftentimes this is due to profound malnutrition and severe vitamin deficiencies. And so these patients require an aggressive workup and consultation with someone who's familiar with these procedures, familiar with the steps if you need to reverse them to some degree, and familiar with the ways to monitor the blood levels of the vitamins and to supplement appropriately. Vitamin deficiencies after these procedures are the norm. Nearly 100% of all patients who have a biliopancreatic diversion or duodenal switch will develop vitamin deficiencies. And on average, the supplementation regimen that you'll need to take for this procedure, because it is a severe malabsorptive procedure, costs $150 per month. If you cannot afford $150 per month of vitamin supplementation, you should not undergo a biliopancreatic diversion and duodenal switch. And failing to take your supplements will be a life-shortening mistake. This will impact your heart function, your kidney function, and result in you being perhaps thinner after the surgery, but sicker than you were before the surgery. The yearly vitamin evaluations that I perform in my office, and this does not include what I perform for patients who've had a biliopancreatic diversion duodenal switch, or any patient who I suspect may have some malnutrition or some medical condition that is related to under or malnutrition. So I have a separate regimen I use, but for just those patients in overall good health, feeling well after their procedure, these are the levels I check. I check an iron profile, which measures not only your total iron level, but some of the binding proteins and other things that are involved in iron metabolism. I check your vitamin B1, which is thiamine, your B3, which is niacin, your B6, which is something called pyridoxine, your B9 level, which is also known as folate or folic acid, your B12 level, which is cyanocobalamin. But again, although we do see a small amount of B12 deficiencies in the sleeve gastrectomy patients, the B vitamin deficiencies are relatively uncommon in patients who eat a healthy diet postoperative. If you're eating a lean cuisine, heavily processed, low-calorie diet, you're going to be more subject to these. But even these foods are often supplemented with powdered vitamins to make them appear healthier than they really are. A vitamin D level, I haven't spoken about vitamin D, but it really is something we see a ton of. I'm not convinced that it has an increased rate after bariatric surgery. It may, but we see so much of it in the non-bariatric population as well. And we check the 25 hydroxy level. There's a second blood tests that you can take, but really for the vast majority of patients, this will be adequate. And then we also check a hemoglobin A1C, primarily, especially in those patients who have been diabetic, because the remission of diabetes is not always lifelong, and we can see some recurrence of symptoms 5, 10, 15 years down the road, particularly with diet noncompliance. We'll make sure that patients aren't starting to develop early onset diabetes. If it is elevated, we're gonna typically start with an aggressive nutritional program and obviously work with the primary care doctor to determine whether any medications are necessary. A note about hair loss, and this is something I talk to my patients about, particularly my female patients about quite often. After a gastric bypass, I think less so after a sleeve gastrectomy and really not at all after a gastric banding procedure, around 1 to 3 months after surgery, many patients will experience some hair loss. The cause of it is unclear, whether it's due to the stress of the surgery, the rapid weight loss, or malnutrition or undernutrition. We're not quite certain, but this is what I see. I see initially some hair loss. It's worse after gastric bypass than a sleeve gastrectomy. And it is much more noticeable in those patients who already have thin or fine hair. In patients who have a really good head of hair, they'll notice it on their brush, but when they look in the mirror, when I look at them, I won't really see a lot of hair loss. So the type of hair that you have will determine how much you're impacted by hair loss. I prescribe in any patient who's interested vitamin B7, which is biotin, at 10,000 micrograms daily as a prophylaxis against hair loss. Now, it does not prevent it, but it probably decreases it at least a little bit in some. In others, it may be very effective. But it's inexpensive. It has virtually no side effects, is well tolerated, and so we do use it for any patients who are interested. We will almost always see hair returning back to its normal levels around month 9 after surgery. So there's really about a 6-month period where you have thin hair, you're losing hair, and then as your weight loss stabilizes, as you're able to take in more of these phytonutrients and other nutrients, you're going to be able to start growing back your hair. And what we typically see is that most patients will return to at least 95% of where they were before surgery, many to just exactly where they were. So although we absolutely do see hair loss, it is not permanent in probably 98% of the cases. When we see hair loss 1 year or further out, this is an absolute sign that you should be checking your iron level to make sure that we don't have iron deficiency. And in any patient in the first year who's complaining of hair loss, I'll be very aggressive in monitoring their iron level and supplementing them if necessary. Thank you very much for your attention. If you have any more questions about weight loss surgery, you can check out any of my videos or subscribe to my YouTube channel. You can also check out my website at www.drmatthewweiner.com if you live in southeastern Michigan and are interested in seeing me for an appointment for any reason, whether you're post-op bariatric surgery, you're interested in having a bariatric procedure, or you're really just looking for some help losing weight without surgery. We offer all of these services out of my office. And we maintain a Facebook page called A Pound a Cure, which is based on my book, A Pound a Cure, which is available on Amazon. Thank you.